Hello, everybody. Oh, goodness. My cat was messing with my green screen. Let's fix that a little bit. It'll be a little bit annoying. Hopefully, the cat doesn't jump up here during the stream. She is a bit needy today. But welcome, welcome, everybody, to Medical Myths once again. We are here probably for the last time before I move to my new location. So we'll be off for a couple weeks. For next week and probably the week after, just until I get the feeling of my new location and my new schedule and all that. So hopefully we'll be back in like 3 weeks, 2 to 3 weeks, but I will keep you all updated as far as that goes. We have somebody has Ben disease in the side chat. Love that. But today we're talking about chronic Lyme, and I don't know how prevalent of a discussion topic this is among most people. I do see that we have people voting yes in the poll. Um, I have seen some advertisements going out on the internet about this, and it's really a controversial issue among the medical community right now. And a lot of that, I think, is because there are, of course, the naturopaths, the homeopaths, chiropractors, functional medicine practitioners that, of course, have jumped onto this bandwagon because anything that is vague and non-specific that they can throw supplements at, of course, they're going to. But this notably has a lot of medical doctors jumping on board as well. And so this can make it more vague and confusing for the patient population because most of the time you don't know which issues are contentious or not when an MD is the one telling you these things. And when the MD is a specialist and working with some top level organizations, it can be very hard to tease out what's going on with this. And furthermore, you have patients who have had years of debilitating chronic disease who are looking for answers, and they get frustrated with our medical system that is not helping them, not providing them with resources that they need, not providing them with a whole lot of options. And so, if you're in that situation where you need to try something, somebody that claims to have an answer is probably going to make some money off of you. And unfortunately, that's what a lot of these people do. They get a following from people who have conditions that are currently being studied and investigated by the medical community. And so, unfortunately, we haven't had a lot of good answers. There is more coming to the surface, though. However, with chronic pain, with chronic fatigue, etc., we're learning more and more about these conditions, and every day we're seeing the science unfold live in front of us, and that takes a lot of time. But there are key things that differ between how the mainstream medical community approaches this versus how a lot of functional medicine and naturopaths, etc., have approached this particular conversation. So we'll kind of jump in first um, with some anecdotes, of course. What exactly is the issue we're talking about? What is the fuss going along with this? Because Lyme disease is a legitimate condition. Uh, we treat Lyme disease. We know that Lyme disease can cause a variety of complications for people over a long period of time. So we know that chronic conditions do come from acute Lyme disease, but this particular Lyme disease that they're talking about is different somehow. It's different than what we talk about when we say complications of Lyme disease. So we'll get into kind of the nuances of what the claims are and what they say. Yeah, we have resources to give people free healthcare. We have it, but people are not distributing them. They're not distributing them at all. So that would be nice if we did that. But we're going to start off with an anecdote and a website by this is Dr. Bill Rawls. He is a physician. I don't it looks like he's not a practicing physician, or at least not practicing conventional medicine anymore. So he practiced conventional medicine for 15 years. However, when Lyme disease and fibromyalgia disrupted his career at age 45, he was forced into the world of herbal and alternative medicine. So, in other words, um, I feel bad that he has like chronic disease. That's not a good situation for anybody. And I will admit that the medical field is very not accessible for people with disabilities. It's very hard to work in medicine if you have disabilities and chronic illness. So I empathize with him on that point. However, taking that information and then starting a scam business is not really the best way to go. So you are not forced into herbal and alternative medicine. You chose that because it's an easier way to make money without actually doing anything legitimate. So, well, it's possible that he actually believes this stuff. It is very possible, but it's also very possible that like he chose this business for a reason. Um, but this was written by him on in this year in June. So he has this whole Lyme disease website. So he says, "What is chronic Lyme disease and what makes me qualified to discuss it? There is so much controversy around this disease because most doctors don't understand Lyme disease." So right off the bat, we have some problematic rhetoric suggesting that I'm the good guy, everybody else is the bad guy. That's a very common tactic we see among alternative medicine discussions is they will get you on their side by making you distrust other people. And so something to think about when we address any of these topics on medical myths, like, are they actually giving you data? Are they giving you a good argument to believe their claim? Or is their entire argument just shitting on other people? Because this like, whether or not other doctors don't understand something, whether or not other doctors are not doing the right thing does not mean that your ideas are legitimate, and it does not mean that your claims are logical and or sound. So when they rely on this argumentation tactic, you can probably guess that they don't have a lot of good arguments on their side, but we'll keep going. So he says even many doctors who consider themselves Lyme experts or Lyme literate medical doctors, that this is a buzzword here used in the chronic Lyme community to suggest that if you agree with what we're saying, you are Lyme literate. And this is something we saw last week as well when we talked about. Uh, we saw this in the carnivore community one as well. We saw this uh, in last week's episode. What even was last week's episode? It was a long time ago. Um, Genetic testing. That's right. The motherfucker gene. We saw it there too, where a doctor who was legitimate is one that agrees with their claims of the MTHFR gene mutations. Same thing here. Doctors that are legitimate are Lyme literate medical doctors or ones that agree with this whole chronic Lyme disease situation. So, but he says, but I have one qualification that most other physicians do not. My life and a busy medical career were disrupted midstream by Lyme disease, though obtaining the diagnosis was quite the journey through multiple diagnoses, including fibromyalgia. So he doesn't in anywhere in this paper, in his blog, I got to stop saying paper when I mean opinion articles. In this article, he doesn't ever say what techniques were used to diagnose him. So I don't know how they confirmed this was Lyme and not a manifestation of fibromyalgia, not a manifestation of chronic fatigue syndrome, etc. I don't know. I don't know if we can confirm that it's Lyme. He says, in my late 40s were marked by debilitating fatigue, tremendous brain fog, aching all over, burning in my feet and tingling in my hands, skin rashes, joint pain, chest pain, heart palpitations, mood changes, and poor sleep. I know what it's like to start and end every day feeling like you have a terrible flu. Over several years, I experienced virtually every known symptom of Lyme disease. So, audience, let's start thinking about our differential diagnosis here. So we have these symptoms. We've got fatigue, we've got brain fog, aching, burning and tingling, skin rashes, like all of these. What other conditions can you think of that would cause these? We've got rheumatoid arthritis. We've got fibromyalgia, like he mentioned. We have mono can cause this. Diabetes can cause this. Any number of autoimmune conditions, such as dermatomyositis, uh, hyper and or hypothyroidism, can cause this, especially the symptoms of chest pain, heart palpitations, mood changes. Some of these can relate to depression, whether primary and a separate issue or in conjunction with chronic illness. The list of differentials is very broad. Just by having this list of symptoms, I can't tell. I can't chalk this up to Lyme disease, especially when I don't have some way to have confirmatory testing. So lots of vague symptoms here that odds are most of the audience is going to identify with. But something interesting here comes up in his next paragraph, and I realize that the font is a little bit small, so we'll zoom in. But he says, however, the obligations of the practice, or sorry, ultimately, this has caused me to stop practicing obstetrics. So this guy, he's a physician. He's not an infectious disease specialist. He is not a rheumatologist. He is not a specialist that would be handling a lot of these symptoms that he's talking about. He's an obstetrician, which they're incredible experts in their field. But why is an obstetrician claiming to be an expert in infectious disease? I don't understand. I don't understand, other than overconfidence and wanting to scam people. So that's a red flag right there. So kind of like this whole article, like the rest of it gets into, like, he found the answers that it's chronic Lyme, and so he wanted to recover his health completely. And he has a whole video here, but he goes more into detail. I'm just gonna hit on a couple points that is gonna carry forward into some of these other articles and be important things to hit on. So their kind of big premises are that lots of people have this condition. They have undiagnosed or improperly diagnosed fatigue, rashes, joint pain, etc. And if you have those symptoms, then since Lyme disease is a differential, we're going to say that everybody has Lyme disease. Their other argument for why it's Lyme disease and not other things is that it's not, they claim it's not uncommon for people to harbor Borrelia and not know it. Stealth is a micro's middle name. So they're going to claim that you can have Lyme disease and not know it. You can be bitten by a tick and not know it. And you can have other co-infections. So if you have these arguments, yeah, and so they say there are more than 20 known species of Borrelia that can cause human illness. We'll get into some of the nitty-gritties of that. And this statement here, all these factors make Lyme disease extremely difficult to diagnose. Lab tests are notoriously unreliable, especially in chronic illness. So think about this. So you have vague symptoms, vague unexplained symptoms. You're going to tell people that all these symptoms are all present in people with Lyme disease. It's possible that you got bitten by a tick and you don't know about it. It's possible that we wouldn't be able to tell that you have Lyme disease. So essentially, it is unfalsifiable. They're making an unfalsifiable claim that you could just have Lyme disease and not know. And there's no way to prove it. Okay, so that's where we're starting with. Going into kind of the next little bit. So I figured we're going to play a little bit with this. So there's a website called lymedisease.org, powered by patients. Do you have Lyme disease? Check your symptoms. So we can go into a symptom checker and see if it'll diagnose us with Lyme disease. Um, but they have on their page, they have all these ads that say, "Do you have Lyme disease? Only 25% of Lyme patients recall a tick bite." So immediately priming people to think, "Oh, this is Lyme disease. I'm going to anchor on Lyme disease, whether or not we can prove it or not." And so they're claiming that chronic Lyme disease patients are profoundly debilitated. And they are also claiming that chronic Lyme is more debilitating than other chronic illnesses. So they're trying to play a comparison card, which this is subjective. All of this is subjective. It's debilitating and horrible and hard to have any one of these chronic illnesses, and even it's like that for chronic illnesses that are not mentioned here. But they're trying to separate themselves and say, we have it worse than everybody else, and trying to get this emotional response out of people to say, I obviously have chronic Lyme because I feel worse than these other people. I don't know if I was bitten by a tick or not, but it doesn't matter. All of this trying to put people into their camp. But again, we have their list of symptoms here, and they'll say 75% of chronic Lyme patients experience severe or very severe symptoms. 63% describe two or more symptoms as severe or very severe. But it's the same kind of general symptoms. We have fatigue, sleep impairment, joint pain, muscle aches, other non-specific pain, depression, cognitive impairment, neuropathy, headaches, and unspecified heart-related symptoms. And so all of these, except for like cognitive impairment, can be like more or less proven. Like you can demonstrate cognitive impairment. Everything else is subjective and based on what you tell us you have. And how you grade severity is also a highly subjective. And so it's very hard to point at like any of these symptoms and say, no, you don't have severe symptoms. No, you don't have that. And I'm not going to do that as a physician. I'm not going to invalidate somebody's experience and say, well, you don't actually have fatigue. You don't actually have severe fatigue. I can't say that. Um, but telling people that having severe fatigue and the fact that a lot of people that have this quote unquote chronic Lyme disease have reported severe symptoms, therefore you probably do too. It's including people into this group to kind of separate themselves and build this identity on something that is unfalsifiable. But let's do the symptom checker. I'm very, very curious. So here we go. I love this ad too that they share. Do you have Lyme disease? Most Lyme patients are initially misdiagnosed with chronic fatigue, fibromyalgia, or depression, saying that if you were diagnosed with chronic fatigue, fibromyalgia, or depression, you're probably misdiagnosed. Come to our online symptom checker and join the club of chronic Lyme disease. And they do give the disclaimer of this can help you document exposure to Lyme and record common symptoms. It is not a self-diagnosis tool. That's only a disclaimer. They want you to take this and give it to your physician and tell them to treat you for chronic Lyme disease. And if your physician does not want to treat you for chronic Lyme disease, then you can write it off as they're just not literate. They are not a Lyme-friendly physician. I'm going to go to somebody who is, which will often put them in the hands of people like Mark Hyman, who we know has very questionable views on vaccines and other things. A lot of these Lyme literate people are very anti-vaccine. They're very, very much pathologizing ADHD autism, etc. So not very up to date on the medicine, not very understanding of uh, the new information and where medicine is going. So they have here, starting off asking about exposure. Have you been exposed to a tick habitat? So they're not specifying which type of tick here. There's just any tick habitat, and you can put yes, no, or unsure. Uh, I mean, in my area, I am in a tick habitat, and I am in a Lyme heavy habitat. However, I'm gonna say, let's say I'm a patient that has symptoms, and I don't know the specific disease map for whether or not Lyme is endemic or if there are ticks around. So I'm going to click unsure. I don't know. And interesting here. So they say people who live, camp, hike, work, or play in wooded or grassy places have a greater risk of being bitten by an infected tick. So basically, trying to tell me if I've been outside, I'm more likely to have been bitten. So I think they're trying to take me from the unsure box to put yes, especially with a particularly high incidence in the East, Midwest, and West Coast. The presence of the black-legged tick, which is now in 50% of all U.S. counties, which is not true. We'll get into that. I'll show you all the CDC disease map. And they'll say risk maps of ticks might not be accurate if tick studies have not been conducted in that county. Fair, but we have a pretty good and accurate risk map. Yeah, and they're not in favor of the CDC. So if I read this and I said, yeah, okay, well, I've been in a grassy and wooded area recently, I'm gonna click yes. Okay, cool. But I mean, just for now, I'm gonna stay in the unsure square and see what it tells me. Do you recall being bitten by a tick? No. And then here, they're priming you again with another question. Only 25 to 30% of Lyme disease remember a tick bite. Ticks are small and their bite is painless. Most human infection comes from nymphal ticks, the size of the period at the end of the sentence. So yeah, so they're again telling you to try to click. Like they're saying, well, you can click this button. It also doesn't matter. So why are you including it if you're claiming that this piece doesn't matter? Have you had a red expanding skin rash? No, I have not. And again, here, they're going to say a distinctive rash shaped like a bullseye is considered characteristic of Lyme disease. Yet this type of rash only occurs in 9% of patients, which I question their statistic. Yeah, CDC reports of rash vary by state and range from 51 to 87%. Yeah, I'm a bit more inclined to accept the CDC report for this very characteristic feature of Lyme disease. And not this one. Like anytime, even if you say no, it's still going to say that you are high risk, which is ridiculous. Like so they're trying to include as many people as possible into the high risk category to then need their services. Early Lyme disease symptoms. Have you had any of the following symptoms of early Lyme disease? Red expanding skin rash? No. Which, I mean, see above, they already told us about that. Facial nerve palsy? No, I have not. Severe headaches and neck stiffness. Well, if I'm a person who doesn't usually get headaches, but I had a headache recently, sure. I have at one point had a severe headache. And at one point have had neck stiffness. Like tension headaches are very, very common and can relate to neck stiffness and severe headaches. For sure. I could put that. I'm sure a lot of people could put that at some point in their life. They've had that. Lightheadedness. It doesn't say when you've had this. It just says, have you had it? Sure, I've had lightheadedness before. I have had flu-like symptoms before. I've had shortness of breath before. But I'll put unsure. I'll put unsure for that one. Shooting pains that may interfere with sleep. I actually have had that. I've had thoracic outlet syndrome, but I'll put no because I'm trying to be maybe a more common person that would respond to this little quiz. Pain and swelling in large joints. I mean, at some point, I'm sure everybody has a little bit. I'm going to say unsure, just to try to be kind of middle of the road. Yeah, and so only half the patients with chronic Lyme disease recall having early symptoms. So even if you don't even know if you had symptoms around the supposed time of your tick bite, also doesn't matter because everybody has chronic Lyme. Um, Symptoms are often dismissed by patients because they do not recall a tick bite or they believe they have the flu. So yeah, they're trying to include as many people as possible in this. Have you had any of the following symptoms of typical of late or chronic Lyme disease? Fatigue. And again, not giving a time frame, not in within the last 2 weeks, not within the last month, not in the last year. Just have you had any of them? Yeah, I've had fatigue. I've had, yeah, frequently. Have I had joint pain at some point? Yeah, but I'm gonna put no because I don't usually have it. Twitching, nah, no, not really. Cognitive impairment, I don't think so. Heart-related symptoms, kind of unspecific. I'm gonna put no. Neuropathy, no. That's a pretty fair no. Headache, yeah, I'll put that. Muscle ache, say I work out sometimes, I'll put that. Memory loss, I have ADHD all the time. Sleep impairment, most people do, absolutely. GI problems, yeah, a lot of people do. I'm even gonna put that because I eat like garbage sometimes, and when I eat like garbage, it's not great. So, um, psychiatric depression, mood changes, absolutely, I do. Um, so yeah, so we're already hitting positive for a good number of these. I'm not gonna I'm not gonna show you all. I'm gonna fill this in and have it sent to my email, and then we're gonna see what it says. Um, and I don't want to receive news from you all. It's asking me if I'm a robot. I'm not a robot. Am I a member of LymeDisease.org? No, and I'm not interested. No, I'm not interested. Yeah, so I'm just submitting this and we're gonna see. I put okay, here we go. So it's gonna and it asked me to share the symptom checklist on my website. Wow. Okay. So let's see what it tells me. Let's see what our results are. I have to open another tab in this very, very long list of sources I've opened. I'm guessing it's gonna take a little bit for that to show up. Unless it went to spam, which is very, very possible. No, I'm gonna wait a little bit for that to show up. Yeah, okay. We'll give it a few minutes. So going on from there, let's talk about what the so we saw what actually no, that's a lie. I didn't want to stop there. I wanted to show you all the board of directors on LymeDisease.org because this is hilarious. So we had the one guy who is the obstetrician. Um, so they have their like they say that their articles are reviewed by their medical directors to make sure that it's up to date and accurate. So you would expect, right? You would expect to have, I guess, chat. Would you expect an organization talking about infectious disease and or rheumatology? Would you expect that their medical board has the appropriate specialists on that board? Would you expect that the appropriate specialists are reviewing the material, or would you just hire somebody with MD at the end of their name and just call it good? Because that's exactly what these people did. They have 3 doctors on their board. This first one is Raphael Stricker, and he's like maybe one of the more close to what you'd want. But he's has an MD and his residency was in internal medicine at Columbia University, but his subspecialty is hemonc. Um, which like they do have some overlap with immunology, and especially like some of the diseases that are tick-borne, like babesiosis. do have an impact. My goodness, Sushi, my cat is on the desk. But like with diseases like babesiosis, that does impact red blood cells. There are a few conditions, like malaria is another one that impacts blood cells. So things that impact blood cells, of course, hematology is going to care about. Other infectious diseases such as HPV, which can cause cancer, another appropriate one for hemonc to talk about. However, Lyme is not on that list. And I'm sorry that you're all now staring at my cat and not me. Um, but yeah, and so he's a member of the American Society of Hematology. Cool. I can be a member. You can literally just sign up for a membership. And that there's a distinction between being a member of these societies and being a fellow of those societies. There are specific criteria you have to meet to be a fellow of your specialty organization. So if he's a fellow of the American Society of Hematology, that would mean something. That would mean that he's holding up to standard credentialing and meeting the standards of the organization. He's just a member. He's a member of the Clinical Immunology Societies. He is a member of the American Federation for Medical Research, a member of the American Society for Reproductive Immunology, American Society of Microbiology, and the American Society of HIV Medicine. And then he is past president of the International Lyme and Associated Disease Society. So something made up. Was on a board for something that was made up. But all these other things, he's just a member. Like, he signed up for a membership. Like, I can literally go in and do that. So, not impressive. But to anybody else, that sounds impressive. So, I don't know why this hemonc specialist is claiming to be a specialist in Lyme disease. That's a little bit weird. The next one, Dr. Christine Green. She is also an MD, and she is family medicine. So, she's a family physician. But also she practices complementary, integrative, and orthomolecular medicine in San Francisco. So she is practicing bullshit. She's practicing alternative medicine, which there are some family physicians that get into that stuff, unfortunately. So she is not invalidated purely on the facts that she is FM. Like, FM is very important. It's a great specialty, but it is not infectious disease expertise. And she's also into alternative medicine stuff, which kind of tells me her critical thinking skills aren't really on point for a lot of these issues. And then finally, we have Dr. Erica Lehman, who is an ophthalmologist, a board-certified ophthalmologist, cornea specialist, and eye surgeon in Beverly Hills. So cool. You do integrative medicine. You claim to be a tick-borne disease specialist. Are you? Are you a tick-borne disease specialist when you are board certified in ophthalmology? I don't know. Apparently, she has like additional focus includes thyroid disease, adrenal fatigue, and GI disturbances. What is an ophthalmologist doing with thyroid disease other than like management of eye-related complications of thyroid disease? Like, of course, if you have proptosis from Graves' disease and like exophthalmos, sure, but I'm confused. I'm very confused about why you believe this is your area of expertise. Anyway, I don't need to take up this whole episode by complaining about these doctors. Oh yeah, and a question about orthomolecular medicine. It's bullshit. I need to do it. I'm planning on doing a medical myths episode on that because it's wild. Yeah, so these are the people that we're up against. It's the CDC or these people, and the CDC and the IDSA versus these people. So now that we've looked at what these people claim about Lyme disease, let's talk about what the CDC thinks about Lyme disease. So we have this topic from the CDC about ticks and tick-borne disease. Key points: in the United States, ticks can spread bacteria, viruses, and parasites that cause human diseases. Many tick-borne diseases have similar signs and symptoms, and ticks transmit pathogens that cause disease through the process of feeding. And there are many, many, many diseases transmitted by ticks. Lyme disease is one of them. We also have anaplasmosis. We have babesiosis, which is one I recently mentioned, which is very similar to malaria, but actually tick-borne. Um, Bourbon virus, cholera tick fever, ehrlichiosis, hard tick relapsing fever, heartland virus, uh, Powassan virus, rickettsiosis, Rocky Mountain spotted fever, soft tick relapsing fever, starry, tularemia, and 364D rickettsiosis. So lots of different diseases that overlap, which sure, you could have some misdiagnosis among each of these different tick-borne illnesses. Um, but that just goes to show you our differential has broadened further because how do you know it's Lyme and not Rocky Mountain spotted fever? Well, actually, Rocky Mountain spotted fever has some very specific symptoms that go with it, but something like starry is very similar to Lyme disease. Same thing with many of these. So and they're saying the symptoms kind of like at least the most common symptoms and the most like acute symptoms, I guess. What you're gonna get first are fever and chills, which all of them can cause fever, aches and pains, headache, fatigue, muscle aches, and you may have joint pain with Lyme disease as well. Rashes, which can be very unique to each specific syndrome. Lyme disease has a very characteristic target rash, which is kind of what they did mention in the symptom checker thing. And it is called erythema migrans. If you have erythema migrans, it is very, very like it's much higher likelihood that it's Lyme disease. Like if somebody came to me and said, I have this targetoid rash, like what do I do about it? Like it could be something else, but that's when it's like, okay, it's maybe more fair to treat this like Lyme disease. But Rocky Mountain spotted fever has a very specific rash pattern. And it's more of a maculopapular rash, I believe. So like kind of what you think of with like a chickenpox rash or like not quite measles rash, because that's kind of those more like can combine into more like a less defined rash. But Rocky Mountain spotted fever has a distinctly different rash than Lyme disease. And part of that is useful in the diagnosis. Um, but something else, like they mentioned, that is very important is before deciding that this is Lyme, you have to take into account symptoms, yes, but you also have to take into account your geographic region to see if it's even high likelihood that you were bitten by the right tick, and confirmatory lab testing. There's also a phenomenon of tick paralysis, which is similar to Guillain-Barré syndrome, um, but that is usually transient. So important things here related to how these diseases spread. So, of course, ticks have hosts. They will, like, depending on their specific life cycle, they will get to the right stage of their life cycle, find a host to feed on. It will attach and start feeding, and as the saliva from the tick goes mixes with the bloodstream, that's how you get infections to happen. And specifically with Lyme disease, let me get to where do they have I guess we'll get into this with the recommendations, but specifically the ticks that cause actually I do want to show another picture just to make this make more sense. So hold on. Here we go. I'm gonna show this one too, because that was for just like all tick diseases, but this one is more specific for Lyme disease itself. So this is the tick. This is the Ixodes tick. And there's a couple different types of Ixodes ticks. There's the Ixodes scapularis, which is usually on the northeastern side of the United States, in kind of in the northern Midwest. And there's also the Ixodes pacificus, which is more in California and along the Pacific coast. So there are key points here about Lyme disease. That Lyme disease is spread by the Ixodes ticks. And in general, infected ticks must be attached for more than 24 hours to transmit infection, and prompt tick removal can prevent transmission. So it takes a long time to get Lyme disease, and that's something people don't really take into consideration. Because sure, could you have been bitten by a tick? How likely is it that you didn't know there was a tick on you? Which you should be checking yourself for ticks. If you live in a tick area, if you go outside, you should make sure that you're not harboring a tick. If you find a tick, remove it quickly, because if it's been less than 24 hours, your likelihood of contracting Lyme disease is very, very low. Not to say impossible, but very, very low. So again, yeah, these are the different stages of the Ixodes life cycle. And it's only female ticks, and it's only within certain life stages. So, but yeah, I love how they have it highlighted here. In most cases, a tick must be attached for more than 24 hours before the Lyme disease bacterium can be transmitted. If you remove a tick within 24 hours, you can greatly reduce your chances of getting Lyme disease. So there you go. And they don't have, I don't think they have a picture of Lyme disease here, but we'll go into what's on there about Lyme disease. They don't have a thing on, trying to find a thing that was showing the Borrelia burgdorferi spirochete. They're pretty cool because they're a little spiral shaped bacterium. So I also love the name burgdorferi. I think it's fun. But this we talked a little about the signs and symptoms of Lyme disease, but this picture is the characteristic erythema migrans rash. So if you see this, and especially if it is expanding and getting bigger, pretty fair to get treated for Lyme disease. And there are different stages of Lyme disease, which we will cover, because some of them do have longer term chronicity. And I'm not denying that there are people who have chronic disease after an acute Lyme infection. However, this is an important point, and this is probably the big reason why I'm contesting a lot of the functional medicine perspective on this, is that there's a difference between the assertion of chronic, vague, unverifiable illness after no evidence of a tick bite, like no evidence of this infection being there, no evidence that the right circumstances were in place, no confirmatory testing, and vague symptoms that could align with other things. That's different than someone who has chronic illness after a known and diagnosed case of Lyme disease, right? So these are completely different. If you have somebody who came in to you and they had erythema migrans, they have like a known tick exposure in Virginia, that, may or may probably was greater than 24 hours, but left this rash, and then they get treated. And if they have symptoms that last even after treatment, that's reasonable. That is a reasonable diagnosis of like post-treatment, like Lyme symptoms. Like that is legitimate. That is not what the chronic Lyme people are suggesting, though. Um, so usually within the course of Lyme disease, you have your early signs. So between 3 and 30 days after, you're going to get that fever, chills, headache, fatigue. You might get some swollen lymph nodes, etc. Um, and the CDC agrees that there are people who don't get the rash. However, the CDC would estimate that it's actually 70 to 80% of infections will have this particular rash. In contrast to the Lyme experts or whatever who say that only like was it 9% of people have the rash. That is a distinctly significant difference between the estimates. And I tend to more likely agree with the people with data on their side. So we're going to say the estimate is 70 to 80% of infected people. Um, you have the rash that begins at the site of the tick bite, which expands gradually. That can reach pretty large diameters. Uh, can be warm to the touch, not usually itchy or painful, and it can appear on any part of the body. It can also appear in places that aren't at the tick bite. Like it can be in a different place. And it doesn't always have to have the bullseye appearance. So it could have usually they have a central clearing at least. There later signs and symptoms, days to months after, you can start getting the severe headaches and neck stiffness. Like probably more similar to feelings of like not as much feeling like a tension headache, but more feeling like meningitis. Other rashes, facial palsies, arthritis, intermittent pain in tendons, joints, muscles, bones, heart palpitations, because you can get Lyme carditis. That is a known complication. Dizziness, shortness of breath, and you can get inflammation of the brain and spinal cord. So yeah, uh, and essentially meningitis, um, nerve pain, shooting pains, numbness, tingling in the hands or feet. So the symptoms that were in the symptom checker, but notice how there's a difference here in the rhetoric between saying that if you have ever had this versus having this days to months after known tick bite, characteristic rash, specific time frame, specific exposure, specific location. The precision is much better with the way the CDC is approaching this. I understand what they're asking for when they ask you, have you had these symptoms all in the same context and within this time frame? Um, yeah, and something here that they do mention, the rash is very similar in appearance to starry or southern tick associated rash illness, but is not Lyme disease. And so that's something important as well when we're talking about endemic zones for Lyme disease. So um, we'll share that. We're going to share the map. Let me pause real quick and just see if there's any comments that I missed. Yeah, 91 of people we already decided have the disease don't get the rash. Yep. Yeah, basically. That's basically what those people were saying. Oh, by the way, uh still didn't get the email. Oh, you know what it was? I told them that I didn't want the emails. So I wasn't gonna get it. Let me submit it again. Let me submit it again. I'm just gonna quickly put in my responses because I realized I guess I do have to actually consent to getting emails. I might do it. Cool. So we'll give that another few minutes and see if it works. Okay, cool. All right. In that case, we are going to go back to this data dashboard. So this specifically, we're playing around with this earlier. This one specifically from 2023, but the trend hasn't changed a whole lot over the past decade or so. And this is currently on Anaplasma, but let's go back to Borrelia. So this is the reported distribution of tick-borne pathogens in 2023, specifically identified in host-seeking Ixodes scapularis or Ixodes pacificus. So following the ticks that harbor Borrelia burgdorferi, and so when we're looking at this map, yellow highlighted counties are projected suitable habitat for the Ixodes ticks, but they are not. It's not known habitat. It is projected suitable habitat. So if the ticks were going to find new places to live, those are probably where they would end up. So it's a future projection, not current data. The green areas are what we're looking at for Borrelia. So we'll look at the legend here. So county status of tick-borne pathogens and host-seeking Ixodes species ticks in 2023. And something that, like, when they were saying that the CDC has unreliable maps, what did they claimed it was? I remember what their stat was. But yeah, it was like, did they say it here for how many? Oh no, y'all can play with this if you want to see more information. But we have the option to look for multiple different tick-borne illnesses. But if we look at the zones, all the green, so primarily on the, like, in the northern Midwest, you get some counties with reported cases in Virginia, and some in North Carolina, although North Carolina is not really much of an endemic state. They've had some cases, but questions arise as well of, like, how many of those cases, like, originated in that particular spot, or like who was doing like some border crossing into where's kind of the overlap of the territory versus kind of deciding that the entire state is an endemic region. So like New York, Pennsylvania has some really, really high amounts of cases. California and Washington have some decent distribution as well. But if you're somebody who lives in like Arkansas, you probably don't have Lyme disease unless you went somewhere recently and had some more exposure. Like if you went to New York or you went to Indiana, and then you went back to Arkansas, sure, that could maybe be a bit more in favor of a Lyme diagnosis. But if you've stayed your whole life in Arkansas, it's probably not Lyme. It might be something else, but probably isn't Lyme disease. Where did I had they had a map. Oh, here we go. Where do ticks live? This is what I wanted to share. So they have map distribution of other ticks on the list. And again, I'm willing to grant that there are people who possibly have other tick illnesses that aren't Lyme. That's totally possible. So here we have, let's just go through them pretty quickly. So we have the American dog tick, Dermacenter, has a pretty wide distribution. Look at that. Let me zoom in a bit more. So Dermacenter is known for transmitting tularemia and Rocky Mountain spotted fever. Highest risk occurs during spring and summer, and it's a pretty wide distribution. So pretty much anything east of Colorado is going to have exposure to this. So Is it Lyme? Could it be Rocky Mountain spotted fever? Could it be tularemia? Again, there's some differences in how those present, but more plausible for our fellow living in Arkansas to have one of these illnesses than Lyme disease. There's also like different kind of subspecies over in California. The Asian longhorn tick. We have this one's not as common. It looked like, yeah, research is ongoing. This is one we don't know as much about, so they don't really have, or they say as of April 2024, longhorn ticks have been found in Arkansas, Connecticut, Delaware, Georgia, Illinois, Indiana, Kentucky, Maryland, all these places. So pretty decent distribution. These were reported for the first time in 2017. So we don't know as much about this one. Maybe we'll see more coming up. Who knows? But it's possible that they carry rickettsia. Cool. So we won't spend too much time on that one. We have Ixodes. Again, most notable for transmitting Borrelia, but also Anaplasma, Babesia, different types of Babesia, different types of Borrelia, Ehrlichia, and Powassan virus. And so this is like an approximate distribution of the black-legged tick, the Ixodes scapularis. However, this is not the same distribution of Lyme disease. So you can have a place where the tick lives, but not have it be a Lyme endemic area. So that's something to note. Even if you live in Arkansas, like we're saying, you could live in Arkansas, you could be seeing these ticks. That does not mean that you're going to see Borrelia in those places, or at least not high amounts of Borrelia. We have Rhipicephalus is another favorite. I just love the word Rhipicephalus. But look at this distribution of Rhipicephalus. It's everywhere. And it's primarily a dog tick. And notable for Rocky Mountain spotted fever. Huge distribution, like the entire country. So again, more likely than Lyme disease. Amblyoma is another one. So this one's another one for rickettsia, a form of spotted fever. So this is primarily in the Gulf Coast. We have that distribution. So again, our people in Arkansas are probably going to see this one. Amblyoma, the Lone Star tick, causes starry, which can be very similar to Lyme disease. Also Bourbon virus, Heartland virus, tularemia, ehrlichiosis. Also notable for transmission of alpha-Gal syndrome, which can cause red meat allergies. So very interesting things with the Lone Star tick. And again, kind of distribution overlapping Oklahoma, Arkansas. A lot of it does overlap a lot of the Lyme areas, but distinctly different. We have the Rocky Mountain wood tick, another germicenter tick. And again, here's this area, Rocky Mountain area. So you can look at, everywhere in the country is going to have some variety of ticks, right? Like, and here's the Ixodes specificus. So like every area is going to have ticks, but not all of these ticks have Borrelia. And so to say that like you live in the US, you've seen a tick before, obviously Lyme disease, not quite. I'm not willing to grant them that. So now that we've kind of addressed the different perspectives from the chronic Lyme community and the CDC, why do we care? Why do we care if people want to say that they have chronic Lyme or not? Why can't we just let people have their label that they're going to use? Well, this has caused some problems, like some really, really massive problems. Which one do I want to start with? That's the question. Where were you going to start? Let's start with a couple of these. Actually, no, I'm going to read something that's a bit more like before I get into the sources. I'm gonna read like more of another like anecdote thing, just to kind of give you a feel of what clinicians are kind of experiencing with this and where we're going. So this is an article just talking about how clinicians can address some of these myths. Like how do we address these myths of the chronic Lyme industry? And this is particularly in Canada, but they say that medical organizations are developing tools to help Canadian doctors talk to patients about Lyme disease at a time when many frontline physicians report feeling ill prepared to counter misinformation about the condition and pressured to send patients for Lyme testing and prescribe antibiotics when they aren't warranted. So they mention a particular ID specialist, Dr. Lenora Saxinger, that is a very cool name. I love that name. But she's an infectious disease specialist and associate professor at the University of Alberta's Medical School. And they conducted an informal survey. And I believe this article is from 2019. So probably around that time, interestingly, like around the COVID time. And so this was an interesting thing to have clinicians go through around the time of the COVID pandemic, was to have this whole thing happening. But that survey of mostly primary care physicians showed that 30% said that they have been pressured to give antibiotics, and almost 90% said that they didn't feel they had appropriate educational resources to offer patients. Health providers and Reddit chats share concerns and frustrations about patients overly concerned about Lyme, often in cases of extremely low probability. And a quote from Saxinger says, "It is difficult to counter some of the misinformation about Lyme because it's spread on websites that actually look very legitimate and very professional. And there's enough misinformation out there that it kind of cross-references itself," which is true. We were seeing that. We're seeing the chronic Lyme people will reference their own people in their own papers, and it looks professional. They have doctors on their medical boards. They sound like they know what they're doing, and so it's very easy to be misled. And so they talk about the misconceptions that we kind of already went over. But despite all of that, yeah, and I do want to cover a couple of these points. Is it testing is an option for patients with symptoms consistent with Lyme for 4 more weeks, but diagnosing early infection is more of a challenge, especially when patients can't identify an expanding rash. There are a lot of things that can cause nonspecific febrile illness, and that's correct. Like if you have an unexplained fever and you don't have kind of characteristic Lyme symptoms, okay, like we have so many things that you need to go off of, and there are tests, and the tests don't work as well in the acute setting. They start working at around 4 weeks. So, and I'll share something about that. And this is a problem because even though you can give the antibiotics to help relieve some anxiety, but they say that accumulated antibiotic risk exceeds the potential benefit by quite a bit. Even though it's a single dose of doxycycline, people can have severe drug reactions, and it feeds into an error-based myth as well. So this is dangerous. And people asking and pressuring their doctors to do this for them is accepting a lot of risk that they don't need to have. And again, when they're only pursuing physicians that will prescribe them this, in the name of Lyme literate physicians, and when they don't get it, they just go find somebody else. You're just increasing the likelihood of having a more severe complication, and you're going to keep going to people that are less and less qualified to handle your care. This kind of leads into some of the other articles that I have. So we have this one from 2019 as well. So you have misdiagnosis of Lyme disease with unnecessary antimicrobial treatment characterizes patients referred to in an academic infectious disease clinic. So I'll just cover some of their key points here. So of 1,261 patients, 911, so 72% of them did not have Lyme disease. 14% had active or recent Lyme disease. 150, so 11.9% had a remote history of Lyme disease, and 1.3% were identified as having possible Lyme disease. Patients without current Lyme disease were more likely to be female, to have had symptoms for more than 3 months, to have higher symptom counts, uh, and to have more Lyme-related laboratory testing, and to have been diagnosed with what were regarded as co-infections. Of the 911 patients without Lyme disease, 83.9% of them had received antimicrobials to treat Lyme disease or their co-infections. The percentage of patients established to have Lyme disease was lower than in earlier studies of referred populations. So there are a lot of people that were thought to have Lyme disease. The majority of them didn't, and the majority of those people that didn't received an unnecessary course of treatment. And doxycycline is a very unfriendly antibiotic. It is not pleasant to have doxycycline. So that's something I would give out with caution. So it's important that we're treating people appropriately. And going to this next one, oops, I clicked the stop share instead of share this next one. So talking about diagnostic testing, how do we confirm Lyme disease? So here's another problem that has come from the chronic Lyme crowd, that errors in diagnostic test use and interpretation contribute to the high number of Lyme disease referrals in a low incidence state. So according to their abstract here, Lyme disease accounted for more than 2/3 of all tick-borne disease referrals to a large academic infectious disease clinic in a low incidence state. Deviations from diagnostic testing guidelines and errors in test interpretation were common, about 65%, suggesting frontline providers need additional clinical support. So kind of just get to some of this. So they have a chart for all the referrals that they got to their infectious disease clinic. Most of them were family medicine, some from internal medicine, urgent cares, etc. Most of them were physicians as opposed to PAs or NPs. The rest of this stuff is not as important. But the chief complaints, the reasons why they were sent to infectious disease were fatigue, arthralgia, so joint pain, neurologic symptoms, rash, and fever, which, in all honesty, these providers did the right thing. Maybe they didn't chalk this up, maybe they chalked it up to Lyme disease and shouldn't have. Instead of putting them into the Lyme disease box, say concern for infectious etiology or concern for tick-borne illness. But this is actually more appropriate, what they did. So these providers that said, hey, I don't know what caused this person's fever. They have fatigue, joint pain, all this stuff of unknown origin. Let's call in infectious disease and let's have them work this up. And so this study actually shows people that did the right thing, sending to infectious disease, and then infectious disease had said, hey, maybe we need to help out a bit more and give our frontline primary care folks some extra assistance, extra education, extra precise guidelines so that they know when it's appropriate to refer, and what testing they can do on their own. So this particular thing was handled fairly appropriately, but here's the thing, though: the large proportion of referred patients were middle-aged Caucasian and female, which those things aren't super important, other than the fact that females oftentimes are not well listened to about chronic disease. So that could be a confounding factor. Is you have women who have been written off by the healthcare system, and they were told that their pain isn't real, their symptoms aren't real, and so in response to not getting help, they go to chronic Lyme people who listened to them and who provided them with a diagnosis to where they know it's not all in their head. And some of that conventional medicine, we need to take responsibility for. We need to treat people better. We need to listen better. And fewer people will probably go to chronic Lyme disease specialists if we actually approach those interactions better. But more than half of them carried a comorbid psychiatric diagnosis, including depression, which, yeah, depression can cause fatigue. Anxiety can cause fatigue. PTSD can cause fatigue. Approximately 20% of patients referred for Lyme disease were taking opioid medications for chronic pain. So a lot of people already had a chronic pain, like illness or associated diagnosis. So that can probably be attributed to, at least some of that could be attributed to that chronic pain that they have. Not to say that it's not legitimate, like it's absolutely legitimate, but let's, instead of saying it's Lyme disease, let's investigate their chronic pain and find out what is the cause of their chronic pain. If it's less likely Lyme, what could it be? Yeah, and this is where I think they get the lower percentage. Like only a few people reported associated skin findings or rash. And most of those skin findings were blisters, folliculitis, poison ivy, and not anything really associated with Lyme. So for diagnostic test results, there are a couple ways that you can, more than a couple ways you can test for Lyme disease. And like this is something really important. And I'm not going to get into the weeds on that here because the testing is confusing for a lot of people to understand. So when we diagnose Lyme disease, the CDC recommends use of an FDA-cleared antibody test for laboratory diagnosis of Lyme disease. As with antibody tests for other infectious diseases, the accuracy of these tests depends on how long you've been infected. So it's true that the longer you've been infected, more likely you are going to test positive. So that is actually contrary to what the chronic Lyme pages say, where they say that the majority of people will never test positive for Lyme, even if they have it. That's not what we know. If you've had Lyme disease for multiple years, you should have antibodies. You should have more antibodies than you did in the earlier phases of the disease. So you may get false negatives in the first few weeks of infection, especially if you have somebody saying here, if you have a patient with the erythema migrans rash, but a negative test, you could still say, hey, this is probably Lyme disease. We just probably won't get a positive test for a little bit. So that's true. That's true. But the FDA cleared assays have good sensitivity after 4 to 6 weeks have passed. So after that point, they're pretty reliable to pick up everybody that has Lyme disease. And so just a quick review of sensitivity and specificity. So when we're talking about a laboratory test, there are two metrics that can tell us whether or not a test is legitimate and if it is useful. Sensitivity is one of them. Specificity is the other one. So sensitivity is a test's ability to detect everybody who has the particular illness. So a highly sensitive test will rule in everybody with the disease, and so that means if you have a negative, you're more likely to actually be negative, because with 100% sensitivity, everybody with the disease is picked up. So if you're a negative, you're a negative. If specificity, on the other hand, is related to how well it can rule out people who don't have the disease. So if you have a 100% specific test, that means that everybody who has the disease is ruled out. Or everyone who, like, it'll say, if it's specific, you are if you have a negative test and you don't have the disease, that's more likely to be accurate. So you're ruling out everybody who does not have the disease. So if you have a highly sensitive and highly specific test, you are more likely ruling in people that do have the disease and ruling out people that don't have the disease. And so the FDA assays have good sensitivity. So they're good at bringing in everybody that has the test. So if we have this high sensitivity, if you have a negative Lyme test, you are more than likely negative for Lyme. Like it is very likely that you don't have Lyme. And they make a very important statement here that once your blood tests positive for antibodies, it will likely continue to do so for months to years, even when the bacteria are no longer present. So if you previously had Lyme and you were treated with antibiotics and your symptoms are gone, if you have a test later, you're probably going to test positive because you're still going to have antibodies. Unfortunately, those antibodies are not protective. So they're not going to protect you from future Lyme infections. But if you're negative from an FDA cleared test, you are probably negative. And they suggest that people that are treated with antibiotics in early stages of infection usually recover rapidly. The people that often have chronic presentations after a known case of Lyme are people that were treated in later stages. So we do know that people that receive antibiotics later on in the course of the disease, we've seen that it's effective, that it'll treat the bacteria, like it'll get rid of the bacteria, but it won't necessarily recover any long-term nerve damage, heart damage, joint damage, etc. So that is a risk for delaying treatment. So that's why we need to have good testing. That's why we need to have appropriate diagnostic criteria to appropriately treat people that warrant treatment and also not treat people that don't. And that's the practice of medicine. That is the art and science of medicine, is knowing who to treat and who not to treat. And that's something that a lot of alternative medicine doesn't understand. They like many lay people overemphasize the desire to treat, but don't understand the importance of when not to treat. And yes, there are risks of co-infection. You can get anaplasmosis at the same time as Lyme disease. However, what they mention here, that these are treated often with the same antibiotics. So if you're treating for Lyme disease, you're probably also treating your anaplasmosis. And if you go to an appropriate specialist, they're going to take this into account and they're going to give you the right antibiotics, even if you need a combination of antibiotics to address multiple conditions, they can do that. And they mention here too, some test providers test patients for Bartonella or Mycoplasma. There's no evidence that these germs are spread by ticks. So there are a lot of tests that the chronic Lyme disease people will say, don't do the CDC or don't do the FDA cleared testing because it's inaccurate. Do our testing instead. And their testing is all over the place, way less accurate. Trying to test people things for like Bartonella or Mycoplasma, which aren't related at all to tick-borne illness. And so don't go with those tests. It's very important that you get the appropriate test. And I know like we usually end around the hour and a half, but we're gonna be going longer because if you thought this story got spicy, just you wait, because there's more, my friends. There's more. So people got angry, of course, with the CDC. They got angry with the infectious disease specialists, the IDSA. So what did they do? They sued them. They sued the Infectious Disease Society of America. And so we're going to go to the case law. So this is the appeal. Um, so there, like the initial case happened in 2021, I believe, and then this is the Fifth Circuit Court of Appeals. Um, before we get into the actual case law, let's go back to the LymeDisease.org page. So they're going to cover kind of what the reasoning was for the lawsuit. So this was after the initial lawsuit. This was written before the appeal happened. So if the appeal happened in November 2023, this was written in September 2023. So in 2021, the federal court dismissed Tory versus the IDSA, a lawsuit brought by a group of Lyme patients against the Infectious Diseases Society of America. The patients have appealed the court's dismissal, and last week had an appeal hearing was held. We don't know when the court will make its ruling. They did it in November 2023. Spoiler alert. So they said a group of Lyme disease patients asked the Fifth Circuit on Thursday to revive their lawsuit against a medical society they claim issued bogus guidelines that insurers used to deny them coverage, forcing some to pay hundreds of thousands of dollars for their care. So reading that sounds horrible, and it sounds pretty on brand for what our medical system does. So I can't really blame people that read this and think, oh yeah, another insurance like thing to get money out of people and deny them coverage. That's so on brand for the US health system. However, they're claiming that the guidelines were issued to perpetuate this. And again, like I understand the mistrust and I understand why people would suggest that. However, let's go into what they were specifically asking for. They were specifically asking for antibiotics. And so forcing them to pay out of pocket for unwarranted antibiotics. That's fair. That's fair. Like if you like a doctor who doesn't want to give you an unsafe medication like for a disease you don't have, obviously like the cost benefit analysis would say, hey, it's better to not use this. And like that doctor putting it on their license to provide that for you and insurance companies like paying for that. Yeah, that's ridiculous. This is funny because like their own thing, like they have something crossed out. So each year, 30,000 people in the US are diagnosed with Lyme disease, according to the CDC. But because not all cases are reported and not everyone knows that they've been infected, CDC estimates, which is fine. I think they're crossing it out because the CDC did not claim that. What was the CDC had, they did have an estimate for how many people have the disease. Where was it? It's probably on the Lyme page. About Lyme disease. No, where was it? They had their I can't find it. I lost the page. But yeah, I just think it's funny that they crossed that out because the CDC is not estimating people that didn't know that they were infected. We're not going to kind of rehash all this stuff. So Lisa Torrey and 27 others sued the IDSA, 7 health insurance companies, and several medical doctors in. So I guess the initial suit happened in 2017. So this was like a whole saga in 2017, and then in 2021, and then in 2023. So suffering from hearing problems, migraine headaches, and an irregular heartbeat, which you can have those things without Lyme disease. You can have any one of those things. Like, in fact, um, arrhythmias, like benign arrhythmias, are actually kind of common, like more common than Lyme disease, I'm willing to bet. So Tori says that she visited 36 doctors, some of whom misdiagnosed her, they're claiming, with multiple sclerosis and fibromyalgia, and said her symptoms were all in her head before she was correctly diagnosed with Lyme disease. And like, I'm not saying that it was correct. If any doctors had said that it was in her head, that was incorrect. That was wrong. They should not do that. However, like having differentials of MS and fibromyalgia are are reasonable differentials. And again, like something here too, that when people oftentimes misinterpret what a physician is telling them in the office. Sometimes a doctor isn't even diagnosing you with a condition, but they might be saying, "Hey, I'm concerned that you might have this thing. Let's continue the workup." And so it's possible that her doctors had said, it's like, "I want to evaluate for multiple sclerosis, or I want to start treating as if you have multiple sclerosis." That does not mean she had a confirmed diagnosis or a confirmed misdiagnosis. I don't know the details, but it's possible that she completely misinterpreted what was being said to her and that she was still undergoing workup. And then she went to somebody who gave her a diagnosis of chronic Lyme, and now she believes she knows better than any physician, and especially knows better than the IDSA. So she blamed her difficulties on the IDSA, a group of more than 12,000 physicians, scientists, and public health experts who treat and develop guidelines and about appropriate care for infectious diseases. Bringing RICO Act and antitrust claims, the plaintiffs claim several major health insurers decided treating Lyme disease was too expensive, so they paid IDSA-affiliated doctors to publish arbitrary guidelines, first published in 2000, that said the illness could be treated with 28 days of antibiotics. Wow. Okay, so they're claiming that that they paid off the IDSA to write arbitrary guidelines. That's not how guidelines work. Like there are issues with insurance providers like covering that. Like more often than not, insurers deny the recommendations. Like it's very rare that insurance agrees with any recommendations, and recommendations are not published to appease insurance companies. Like these are separate things. Like doctors are some of the most annoyed with insurance. So like the fact that they think insurance and physicians are working together is quite laughable. It's really laughable. The plaintiffs also claim that they had trouble finding doctors who would treat them because IDSA insurers referred physicians who criticized the guidelines as too restrictive to state medical boards, and more than 50 were investigated, disciplines, or had their licenses removed. Yeah. So they're like, we're being persecuted, or the physicians that are Lyme literate are being persecuted as being too restrictive, and insurance won't cover my quack alternative medicine provider who got their license revoked. Like, yeah, okay. Like no one has to cover coverage. And in fact, it's better if they don't cover coverage from a physician that had their license revoked. Okay. Like that's just called regulation. Like, would you rather, it sounds like you would rather have doctors that are unregulated, which is really, really scary. Long-term Lyme disease has been a subject of controversy for years. The IDSA's 2000 guideline says there was insufficient evidence to regard chronic Lyme disease as a separate diagnosis. Yeah. Its 2006 guidelines stated, in many patients, post-treatment symptoms appear to be more related to the aches and pains of daily living than to either Lyme disease or tick-borne infection. Tori says that due to the association's guidance, she has been forced to pay hundreds of thousands of dollars to treat her Lyme disease because her insurers have denied her coverage. After reaching confidential settlements with the insurers, the plaintiffs filed a second amended complaint in January 2021, adding fraudulent and negligent misrepresentation claims against the IDSA and its panelists who wrote the guidelines. The plaintiffs further whittled their case in April 2021 after lodging a third amended complaint by dismissing the panelists as defendants and their RICO claims. The U.S. District Judge Robert Schroeder, a Barack Obama appointee. So, of course, they're saying like this person was associated with Obama, therefore, obviously against us. Sided with the IDSA in September 2021, first dismissing the challengers' antitrust claims and their misrepresentation allegations in a separate order 2 weeks later. The appeal. Tory and Company appealed to the Fifth Circuit in the next month, but the IDSA convinced the New Orleans-based appellate court to dismiss the appeal as premature because blanket settlements with the health insurance had not been finalized. Reasonable? Okay, like you haven't finalized your settlement yet. It's reasonable to delay the appeal for that. They filed another appeal in November in the same court. Representing the Lyme patients, Kendall Spear of the Houston firm Rusty Hardin and Associates said Schroeder had erred by concluding plaintiffs could not win on their misrepresentation claims because the statements in IDSA's guidelines were medical opinions and not held out as facts, which is absolutely true. So, and we'll see this in the actual appeal. So medical guidelines, they're guidelines and recommendations written by the specialty organization to say, hey, this is what the data suggests is the best course of action. And they have laid out the strength of the evidence. They'll say, like, here's the recommendation. Here's how strong this recommendation is. And like, if we would do this for every single patient, or if there are certain patients we would do this for, or if we recommend against this thing because the cons outweigh the pros, etc. They give clear stratification of the level of evidence and the level of confidence in those recommendations. And ultimately, it is up to separate physicians to make their own decisions. Like that's what practicing medicine is. You have your own license, you have your own practice a lot of the time, or you work with a group, and you can only know so much as a person. Like you can't be an expert on everything. And so when you have questions or when you need a specialist opinion, instead of always referring, you can go to their guidelines and say, okay, what can I handle on my own? What do I need a specialist to do with me? And guide them through that process. It is not like it's kind of hand-holding a little bit, which is we kind of need that. It is not holding a gun to your head saying you have to do it this way or else. It's a recommendation, and you can go against recommendations for very specific reasons. Like if your case has a variation that makes the recommendation unsafe, that is your decision to make as a clinician. And the plaintiffs in this case really didn't understand that guidelines are not, like, they're not going to hold a gun to your head if you don't adhere to these guidelines. But if you don't follow guidelines, you could be fired from a group practice. You could have a higher likelihood of malpractice suits brought against you because, like, the standard of evidence in malpractice suits are like, is the action that you took reasonable, and would one of your peers make the same decision under the same circumstances? And if you have a set of guidelines that say, this is what we would do under these circumstances, and you did something completely the opposite, it's much more easy to go to court and say, hey, this doctor fucked up, because these are clearly the guidelines that any reasonable physician would do. So again, it's not making you do these things, but it brings into question how well you're practicing medicine because you're not willing to ask for help when you need it. Regulation is important. And so they say that here. Schroeder also said the plaintiff's doctors can review the studies and papers cited in the IDSA guidelines and make their own assessments about their accuracy. Yeah, there you go. But Spear argued her client's doctors are not capable of exercising their own independent judgment on the proper way to treat this is a fun typo. Lyme disease due to substantial power and influence the IDSA has in dictating how physicians care for such patients. Yeah, and so this is where it gets funny too, because they're going to bring in some more politics on this. So like they get angry about anyone associated with Obama, but now they're like, so they're leaning towards dismissal. And my concern here is there has to be a forum for debating scientific questions. The Donald Trump appointee told Spear, and this is a scientific question: how to treat this. We all know that there has to be a forum for that. We can't have lawsuits against people who are trying to debate the scientific question in forum. So it's odd that like, so they're using the Donald Trump side to also be. I'm very confused about their political leanings at this point, because like they're just anti anybody, but like this person has a point, like for dismissing the lawsuit. There's a legitimate point here that you need to allow the IDSA to have continuing debate and discussion about what the appropriate guidelines are. You have to allow physicians to have variations in their practice. You have to allow them to have this form of discussion. So I will give that Donald Trump appointee that. Yeah, and the IDSA, of course, played up Duncan's concerns. New evidence can always come along. New drugs can always come along. If you allow these misrepresentation claims, it's very dangerous to quash that debate, argued Dunn, who is with the Washington firm Pillsbury Winthrop Shaw. Spear, the challenger's lawyer, countered, it is plausible doctors are effectively bound by the guidelines, evidenced by the fact that more than 12 states have passed legislation to protect physicians' ability to prescribe long-term Lyme treatment. So again, like regulated on state levels. And again, that kind of leads into more concerns about like what role should legislation have in determining medical guidelines. That's a whole separate question for a different day. We've taken enough time with this. But that's the LymeDisease.org interpretation of all this. And they're like the details of the case, they actually got pretty correct in that particular article. But here's the appeal that happened after that. And we will just try to skim through this because who wants to sit back and read case law on a Saturday? Not me. I did not go to law school for a reason. But we'll kind of read the intro. A professional society in specializing in the study and treatment of infectious diseases published guidelines in a peer-reviewed medical journal for treating Lyme disease. Individuals who claim to suffer from persistent Lyme disease symptoms sued the society, alleging the guidelines harmed them by casting doubt on how chronic Lyme disease should be treated and even whether the condition exists. The district court dismissed the claims because it concluded that the statements at issue were non-actionable medical opinions and not factual assertions that could support a claim for fraudulent or negligent misrepresentation. We affirm. So they agree. They agree with the district court. So kind of going back through this. So plaintiffs are people who claim to suffer from chronic Lyme disease. A person contracts Lyme disease from ticks carrying the bacterium Borrelia burgdorferi, and they give a citation here. Typical symptoms are fever, headache, swollen joints, fatigue, and rashes. Many patients respond to short-term antibiotics, but some do not. This latter group is said by some to experience post-Lyme disease syndrome, post-treatment chronic Lyme disease, or chronic Lyme disease. The nature of chronic Lyme disease and how to properly treat the condition are matters of scientific dispute. Plaintiffs allege that some doctors accepting the phenomenon's existence recommend a holistic approach that may include long-term antibiotics. Others take a different view, like the defendant here, the Infectious Diseases Society of America, a professional society of doctors, scientists, and other healthcare professionals. Um, and we went into kind of all the reasons why we doubt that chronic Lyme is even a thing, and why they don't recommend long-term antibiotic therapy. In November 2017, plaintiffs sued IDSA, 6 health insurance companies, and a health insurance trade association, collectively the insurance defendants, and 7 doctors, the doctors who were among the 14 authors of IDSA's 2006 guidelines. Plaintiffs alleged that the insurance defendants paid the doctors large consulting fees to include baseless treatment recommendations in the guidelines, which in turn would allow the insurance defendants to deny coverage for chronic Lyme disease. Plaintiffs asserted claims under the Racketeer Influenced and Corrupt Organizations Act, RICO, as well as the Sherman Act. And so talking about like how they settled with the insurance defendants and then, had the second and third complaints as well, added their misrepresentation claims, etc. And so all this, so this part is like a little bit interesting for the third complaint. So actually, well, here we go. Yeah, we can read this. We can read these complaints. So we review de novo a Rule 12 dismissal for a failure to state a claim. So failure to state a claim, a complaint that fails to state a plausible claim, a facially plausible claim must be dismissed. Facial plausibility means factual content that allows the court to draw the reasonable inference that the defendant is liable for the misconduct alleged. Cool. So they disregard conclusory allegations, unwanted factual inferences, or legal conclusions. So they dismiss for those reasons. Next, they talk about the plaintiffs argue the district court erred in dismissing the misrepresentation claims against the IDSA. They contend that the guidelines properly read do not merely report medical opinions, but instead make factual representations about the proper treatment for, and indeed the very existence of chronic Lyme disease. We disagree. Instead, as explained below, we agree with the district court on the guidelines, that the guidelines are medical opinions, not factual representations, and cannot form the basis for a claim of fraudulent or negligent misrepresentation. Before beginning our analysis, we say a brief word about the applicable law. So they cite the relevant statutes. We don't need to go into all that, but plaintiffs appear to agree that merely publishing a medical opinion, even a hotly debated one, in a peer-reviewed journal cannot give rise to a misrepresentation claim. So even the plaintiffs agreed with that, but nonetheless decided to press forth with their appeal. What plaintiffs do argue, however, is that the district court failed to read the guidelines statements about chronic Lyme disease in context. So it was a funny thing, similar to a lot of biblical arguments of like, you have to read the verse in context. You have to read the statements, the guideline statements in context. Had it done so, they contend the court would have seen that the guidelines do not merely report opinions, rather make factual assertions needed to influence doctors and insurance companies. These arguments miss the mark. Yeah, they heavily miss. Like they're claiming it's a conspiracy, and they just need to read it in context, and they will obviously see the conspiracy. Plaintiffs contend the district court literally read the guidelines without considering the perception of them as applied by medical. So they want them to read the guidelines without considering the perception as applied by medical practitioners, other researchers, and influential players within the medical community. Yeah, so you read them as a layperson, you're probably misinterpreting them, because these guidelines are meant for practitioners. You should read them as they would be applied by practitioners. Like, this is very similar to what we see with sovereign citizens, and how, like, yeah, anybody can read the law, but not everybody is trained to interpret the law. And not everybody is going to utilize that appropriately within the professional setting. Like, just because you can defend yourself doesn't mean you should in a court of law. Like, that's dumb. And a lot of people know that's dumb. Why do we think that we can do the same thing with medicine? Why do we think that like lay people can apply medical guidelines that they aren't trained to read and interpret? Like, that's ridiculous. Like, these people, honestly, like, they're the soft of medicine. Um, like, alternative medicine is they are the soft sits of medicine. Like, your rules do not apply to me. Um, yeah, this is hilarious. Yeah, so of course the court disagreed with that. To the contrary, the district court explicitly recognized the guidelines context. It noted that the guidelines set forth explanations of medical research, experiments, and knowledge based on citations to other published studies and clinical trials, not naked assertions of fact. Going on to the next paragraph here, and I promise we'll kind of get done with this segment momentarily. Plaintiffs also contend that the guidelines show that the IDSA tried to bury or explain away treatment failures, which plaintiffs interpret as the organization's skepticism and overall disapproval of the studies relating to instances of chronic Lyme disease. This argument is unavailing. Contrary to plaintiffs' view, the guidelines do not become actionable factual representations merely because they disapprove of studies the plaintiffs prefer. Yeah, you don't get to say that they're burying or explaining away things just because they use studies that you don't like. Cool. I think yeah, they kind of just repeat a lot of the same things. Their argument's kind of consistent all the way through. So kind of the thing I want to leave us with, firstly, are the actual guidelines. Let's look at the guidelines. Let's look at them. So here we have, these are actually, they were talking about the 2006 guidelines. We have new guidelines now. We have the 2020 guidelines. Amazing. We're going to go through the 2020 guidelines from the IDSA for the prevention, diagnosis, and treatment of Lyme disease. And we're going to read the abridged recommendations because we don't need to go through the whole paper. It's too much. So you can see that it's very clearly laid out. The context is very, very clearly specified. And there's a lot said here that can pretty easily be misunderstood. But which measures should be used to prevent tick bites and tick-borne infections? Number one is personal protective measures. Individuals at risk of exposure should implement personal protective measures to reduce the risk of tick exposure and infection with tick-borne pathogens. So wearing appropriate clothing when going outside, using like bug repellents, making sure that you're checking yourself for ticks, removing the ticks within a timely fashion. So there you go. Good practice statement. Repellents to prevent tick bites. For the prevention tick bites, they have a whole list of things that they recommend. I know there's a question about using DEET in tick repellents, but you know, like people don't use that much anymore. But you can even use lemon eucalyptus oil. Like use your goddamn essential oils if you want to, like to repel them. Strong recommendation, moderate quality evidence. So they give you clearly listed here how strong their recommendation is and what tier of evidence they're citing. They recommend removing the attached ticks. Which diagnostic test should be used following a tick bite? So A is we recommend submitting the removed tick for species identification. Yeah, good practice statement. If you have a tick attached to you, or if you removed one from you, hold on to it, save it, bring it to the doctor's office. They can send the tick for species identification. They do not recommend, so they recommend against testing removed Ixodes tick specifically for Borrelia burgdorferi. So strong recommendation, moderate quality evidence. And so their comment is that the presence or absence of Borrelia in the Ixodes tick removed from a person does not reliably predict likelihood of clinical infection. So if you have a tick and you know it's Ixodes, or you think it's Ixodes, you can send it for species confirmation, but you don't need, it's not worth it to test it for Lyme itself. Diagnostic testing of asymptomatic patients following tick bites. We recommend against testing asymptomatic patients for exposure to Borrelia following an Ixodes tick bite. Strong recommendation, moderate quality evidence. And getting into some of the meat here. Who should receive antibiotic prophylaxis to prevent Lyme disease following presentation with a tick bite? We recommend that prophylactic, here, I'm going to highlight this for you all. We recommend that prophylactic antibiotic therapy be given only to adults and children within 72 hours of removal of an identified high-risk tick bite, but not for bites that are equivocal risk or low risk. So they have a risk stratification system here. So if a tick bite cannot be classified with a high level of certainty as a high-risk bite, a wait and watch approach is recommended. A tick bite is considered to be high risk only if it meets the following three criteria. And I'll highlight these for you all. The tick bite was from an identified Ixodes species vector species. B, it occurred in a highly endemic area. So C, the map we showed earlier, and C, the tick was attached for more than equal to or more than 36 hours. So if you're asymptomatic, and like you have any of these, like if you have all of these three criteria, so you have to meet all of them, then you get antibiotics. This is for asymptomatic people. What is the preferred antibiotic regimen for chemoprophylaxis? So the prophylactic dose, of course, we don't really care, is single dose doxycycline within 72 hours of administration. For preferred testing strategy for erythema migrans. So if you have the rash, in patients with potential tick exposure in a Lyme disease endemic area who have one or more skin lesions compatible with erythema migrans, we recommend clinical diagnosis rather than laboratory testing. So at that point, you have the rash that is characteristic. You have enough data to say, hey, it's probably Lyme. Let's just treat. In patients with one or more skin lesions suggested of but atypical of erythema migrans. So if it's not the characteristic targetoid rash, but like could possibly be, then you do antibody testing rather than currently available detection methods such as PCR or culture performed on blood or skin samples. Which is funny because the obstetrician that says he's a Lyme expert talks about urine testing. Do not urine test for Lyme. Like that's not reliable. So the gold standard is antibody testing on acute phase serum sample, not PCR and not cultures. If needed, the convalescent phase serum sample should be collected 2 to 3 weeks after collection of the acute phase. So you can get a second test 2 to 3 weeks after the initial test. And then again, treatment with doxycycline. And how long should a patient be treated if they have erythema migrans? Either a 10-day course of doxycycline or 14-day course of amoxicillin, cefuroxime. So you can use a couple different things. And then they go into, like, if they have Starry and not Lyme, if we think it's Starry, what are we going to do? In certain geographic regions where both Starry and Lyme are endemic, then you have more reason to treat for Lyme So they say when STARI cannot be distinguished from Lyme disease uh, in areas endemic for both conditions, antibiotic therapy directed towards Lyme is indicated. So in illness referred to as STARI, we make no recommendation for or against the use of antibiotics. So there's kind of a knowledge gap there for STARI. So kind of not as helpful. And then they go into diagnosing Lyme neuroborreliosis, which that's a big thing. Like, you can have neurologic symptoms. We do know that. They give parameters of their recommendations for when you should image for it, when you should test people with neuro symptoms for Lyme disease. Like, they have a lot of recommendations. They also give recommendations for who should be hospitalized, what you should do about carditis, what you should do about arthritis. And here you go. What are our approaches to patients in whom Lyme arthritis has not completely recovered? In patients with Lyme arthritis with partial response after a first course of oral antibiotic, we make no recommendation for a second course of antibiotic versus observation. So there is a little bit of a knowledge gap there for people with partial response. But when people with no response, then they say, like with Lyme arthritis, but this is again in people with confirmed Lyme, then you can do some longer courses of antibiotics. I wonder what they have in their note, because I didn't see a whole lot here as far as chronic Lyme. They didn't go as much into that in this particular set of guidelines. But anyway, that's kind of the long and short of the guidelines. But I want to leave us with kind of what this lawsuit did to this discussion, to the debate, and where we're going forward with this. So this was in 2022. So after the first, like the initial suit and before the appeal. And this is more of it's written like a study, but this is more of an opinion piece. So I'm not citing this as evidence, but this is just some insight into kind of what the aftermath was of this. So they say a federal court recently dismissed a case against the IDSA brought by a group of patients with Lyme disease. While the outcome represented an important victory of the IDSA, I argue it should also serve as a turning point in our approach to patients with chronic Lyme disease, many of whom experience substantial symptoms and suffer an emotional burden due to the uncertainty of their diagnosis. As the incidence of Lyme disease continues to increase and the geographic range of the vector expands, infectious disease specialists, experts in history taking, physical exam, and diagnosis should play a leading role not only to combat pervasive misinformation, but more importantly, to benefit patients. And so this is from an infectious disease specialist. So it says, debate over the concept of chronic Lyme disease has contributed to policies that exclude patients from specialist care. Many, if not most of these patients experience substantial symptom burden, are seeking trustworthy information, and benefit from infectious disease consultation. So saying that we have a lot of these people that are concerned, they have long-term symptoms, they're concerned about if they have chronic Lyme, and since many people in the medical community are frustrated with the misinformation, they've been turning away people from specialist evaluation, and then those people go to these chronic Lyme experts and get worse information. So this person is saying, like, what is the burden? What is the duty of infectious disease specialists to help combat these myths and also listen to these patients, provide an appropriate evaluation and appropriate recommendations? And saying that we should support infectious disease physicians in being the primary source of combating this misinformation. And so they kind of recap that the lawsuit alleged that IDSA and other defendants had engaged in decades-long conspiracy to deny the existence and prevent treatment of chronic Lyme disease. In his dismissal, the judge held that the IDSA guidelines, as most clinicians are aware, represented a summary of current medical knowledge, and adherence to the recommendations was voluntary. The outcome represents a clear and important victory for the IDSA in the decades-long contentious debate over Lyme disease, and more specifically, chronic Lyme disease, a catch-all term that now encompasses residual symptoms after treatment of a documented infection, also known as post-treatment Lyme disease syndrome, as well as the presence of non-specific symptoms without objective evidence of infection, spurred by a range of activist and advocacy groups. At the most extreme, these groups have peddled anti-science tropes and conspiracy theories, occasionally propagated by high-profile leaders of questionable character. Despite the lack of evidence, many of the ideas espoused are now well-established in the public square and are ubiquitous on the internet. While the decision brings the legal matter to a close, the fundamental challenges remain. The incidence of Lyme disease continues to increase as a geographic range of the vector expands to new areas. Surveillance for ticks and tick-borne pathogens is uncoordinated and underfunded, and there are very few effective strategies to control tick populations. On the clinical front, existing diagnostic assays and testing algorithms, which rely on the development of host antibodies in response to infection, are of limited utility early in the course of infection and are frequently misapplied and misinterpreted. Which I didn't get too much into detail on that, but yes, they are very, very highly misinterpreted. Meanwhile, there is a substantial patient population that perceives their symptoms, suffering, and experiences, Lyme-related or not, are being dismissed. And even as researchers rush to tackle long COVID, another incompletely understood post-infectious syndrome that shares many similarities with post-treatment Lyme disease. So yeah, this is a problem. We have people that mistrust the medical system, don't have access to appropriate resources, have abundant access to poor information and poor research. And we're not meeting the public need. We have people suffering without access to care, without access to proper recommendations, and we're turning them away. We need to fix that. And I hope that, some improvement has been made since 2022. I know not much, but I think that the response to chronic illness has improved slightly. There are more studies looking into responses to pain, different strategies to pain management. I've changed my own beliefs on pain management since 2022, and I started med school in 2019. And so I went through medicine as it was starting to change these ideas. So yes, I do agree. We need to find better ways to meet this population where they are and provide them better care. At the same time, physicians and scientists are reluctant to speak on record about the topic, let alone aggressively refute misinformation. More worrisome, clinicians may be wary of seeing these patients due to uncertainties regarding the diagnosis and treatment of post-treatment Lyme disease syndrome, concerns about unaddressed mood and psychiatric disorders, and even fear of confrontation. For example, I practice in a state at the leading edge of the epidemic, but one that is historically classified as low incidence. While the epidemiological data show a substantial rise in cases, many infectious disease practices in my area, both academic and private practice, refuse to accept referrals for Lyme disease. A large proportion of more than 100 referrals I see each year are on their second or third attempt at getting an appointment. Many patients, frustrated with the inability to see a specialist, pursue care with self-professed Lyme literate providers who frequently administer invasive and at times harmful interventions of dubious effectiveness. So where are we now? I'm generally cautious in my use of battlefield metaphors, having spent 2 years at war in Iraq. Nevertheless, considering the recent history of Lyme disease, I keep returning to the concept of collateral damage. In counterinsurgency warfare, collateral damage frequently becomes the source of propaganda and misinformation that can spread quickly through the population and ultimately may influence so-called fence sitters to turn against the larger campaign. At that point, attitudes become fixed and the war is lost. And yeah, that I agree with a lot of the sentiment regarding alternative medicine. We need to reconsider how we're engaging with this. While the comparison is a bit extreme, I do worry that we may be in fact be contributing to the spread of misinformation through our inaction. When patients are told that their condition does not meet criteria or nor otherwise warrant an evaluation, we are often telling them, intentionally or not, that their symptoms are not real. In doing so, we are not only feeding their narrative of the conspiracists, but also seeding the ground to the profiteers and charlatans. Policies that deny chronic Lyme referrals are particularly harmful because many of these referrals are not driven by patient demands, but by providers themselves. And yeah, that's true. Like the referrals are from providers asking for help. And it would at least be nice to have a specialist say, hey, yeah, I understand you have questions. You don't know how to approach this very contested topic. Let us assist you in this. And that's what a referral essentially is. In my own practice, I see very few patients with epidemiological risk factors for or symptoms typically associated with Lyme disease. Instead, most patients have had testing for Lyme ordered as part of a workup for nonspecific symptoms like fatigue, chronic pain, or poor concentration, often described as brain fog. Testing seems to take place well into the diagnostic course after other more common causes have been considered, and both patients and providers are searching for clues. Thus, when a Western blot is performed after a negative enzyme immunoassay and one or two immunoglobulin G bands return positive, there's often a reflexive response to diagnose and treat, even though such a result could be interpreted as a negative test. So people interpreting tests that don't quite know the nuances of it and then reflexively treat, giving people the assumption that they're being treated for a confirmed case of Lyme disease, which may not actually be accurate. When a course of doxycycline predictably fails to resolve the symptoms, patients may receive another course of antibiotics and the descriptor chronic gets added to the diagnosis. So you get somebody who doesn't really know how to interpret the testing. They send a referral to a specialist for help saying, hey, can you help me with this diagnosis? They say no. So you're trying the best that you can to interpret the test. You say that it's positive. Because as far as you know, as a non-specialist, it looks the same to you. So you tell the patient, okay, let's treat you for presumed Lyme disease. So the patient says, oh, I have Lyme disease. Great. You give them the course of antibiotics. And because it wasn't actually Lyme disease, they don't get better with the antibiotics. And then you try again. You say, okay, well, maybe we'll add some more antibiotics. Maybe it just wasn't long enough. And of course, it doesn't work. And then they're stuck with this chronic illness that they have a label for. They've already applied a label for. They're going to keep accepting that label for it, but nothing helped it. And now they don't have a specialist to see, and they don't have other options for treatment. They don't know where to go. They don't know how to reevaluate because they're so stuck on this one diagnosis. When I see these patients, most could be described as fence sitters. In other words, they're not anchored to the diagnosis, but they are concerned, especially if they spent time searching for information on the internet. They've come to see an infectious disease specialist because they are seeking reliable information from what is, thankfully, still considered a trustworthy source. So you've got them at a point where they maybe have done some reading on the internet. That is not the best, but they're not so far into the conspiracy that they're willing to see a qualified physician, a qualified specialist. And so now is the time. Now is the time to help them because they still view you as trustworthy. And so you can evaluate and you can say, he says, by taking a complete history, performing a thorough exam, and then walking patients through the basics of immune response in relation to their test results, I have found that the overwhelming majority are simply relieved. On occasion, I'm able to identify an alternative cause of a patient's symptoms. In North Carolina, where Lyme is emerging, but not yet seen in rates similar to that in the Northeast, The clinical manifestations of ehrlichiosis, spotted fever, rickettsiosis, and alpha Gall syndrome are frequently misattributed to Lyme disease. In circumstances where patients are still uncertain, and particularly in cases where testing algorithms have not been followed, I'll repeat test, including Lyme serologies. Of course, on more than a handful of occasions, my pre-test assessments have been wrong, and in those cases, I have treated patients. So yeah, it still could be Lyme, but just like evaluate more differentials, be willing to be wrong and change your perspective. But this is how we should approach it. This is the proper doctor patient relationship. Validation of the concerns, listening to them, taking it seriously, doing the best you can to get to the bottom of it, and treat what you can. Like people aren't asking for the world. At least most people aren't. People are asking for effort. They're asking for effort, and I think we can provide it to them in this way. And this person, like, even had said that. I might as well just read this. This is the last paragraph. Overall, my experience with chronic Lyme referrals has been professionally fulfilling. While these visits usually require 45 to 60 minutes, and this person's fortunate to be at an academic institution that affords him this time, these encounters allow me to apply my knowledge to the differential diagnosis and evaluation of unexplained symptoms, one of the very reasons I was originally drawn to the field. Furthermore, multiple studies have shown that infectious disease providers are frequently able to identify other causes of patient symptoms, which almost certainly contributes to better health outcomes and satisfaction. Even when I don't have a clear answer, patients generally feel reassured that their symptoms are not attributable to an incurable spirochete, and where appropriate, I'm often able to steer patients to colleagues in fields such as rheumatology and neurology. Yes, I've had a patient throw her medical records in my face and curse at me, but these events are very rare. I feel more defeated when I'm unable to convince someone that they don't need a central line and an antibiotic cocktail, let alone things like ozone or colloidal silver. Still, as a field that has published many, many papers demonstrating improved outcomes for conditions like bacteremia and candidemia with our involvement, we should not raise the white flag on patients referred for chronic Lyme disease. Undoubtedly, there has been collateral damage, but we have an important role to play in developing better diagnostics and management pathways and should not be afraid to lead from the front. I love this person. I love this paper. Yeah, I love this. I love this assessment of the situation. And yeah, addressing some of the comments in the side chats. Um, would it make sense to refer patients with these symptoms to both ID and rheumatology to work through differential diagnoses? Yeah. Yeah, depending on the symptoms, I think there are a lot of symptom overlap that I reasonably would refer to both. Um, so yes. Trying to see if I missed any other comments in the side chat. I know we went longer today. But I felt like there was a lot of good content on this subject matter. Um, so thank you everybody for joining me today. Please continue to leave your comments below, and thank you everybody for joining me in the side chat. It was a great turnout today, and we'll be gone for the next couple weeks while I get ready to move. But I hope to be, other places on the internet, find me in other people's side chats, etc. But my energy is going to be uh, focused more on the stresses of real life. But thank you everybody for being here, and I will see you all in the next one. Bye, everyone.